do.
Exceptions to informed consent.
The first exception is emergency, or when a patient is in a life-threatening situation and can't consent. The second is incapacity, when a patient cannot consent, involve a surrogate decision maker. There is also something known as a patient waiver. When the patient says they do not want to know any more and let the clinician do what they think is best, this is known as a waiver. The patient is waiving their rights to an informed decision, and the clinicians will do what they think is best. The last exception is therapeutic privilege, which we have already discussed. This is when you believe that informing a patient will make them go off the deep end. And usually, if you have used this once in your career, you have used it too many times. It should not be an excuse for paternalism. Implementing informed consent.
The implementation of informed consent can be very difficult, especially if you are working in a tertiary care facility where you may only see a patient for a certain amount of time, where you may be a floor nurse or an ER doctor. You may not actually see the patient through their whole care trajectory, so sometimes the relationship is brief, but you should not sacrifice quality. There are two models that we use to guide the implementation of informed consent. There is the event model and the process model. The event model says that the clinician meets the patient, explains the procedure, obtains consent, and a signature. In the process model, there is more time for that relationship to evolve.
The nurse's role.
The nurse's role in informed consent can be very complex, and it has been progressively so over the last few decades as more collaboration occurred. In certain cases, the nurse is the chief clinician in charge. Certain nurse practitioners have full prescriptive authority. Therefore, they're the clinician in charge of obtaining informed consent. For nurses who are not nurse practitioners, there are other tasks that the nurse can help with. They are at the bedside the most, so they can help ensure the capacity of the patient is there. They may see things that the doctor or other clinicians don't, and there should be discussions about those things. The nurse frequently asks all kinds of questions, and thus must be knowledgeable about the information that the patient is privy to. And there should be a united front in the information given to patients.
Responsibility versus authority. A paradox.
There is a paradox between responsibility and authority. In the current environment, physicians and not nurses make decisions about treatment. In this role as the patient educator, the potential exists for nurses to appear to challenge the traditional authority of the physician, which is why I mentioned that information should be consistent among the entire clinical team. Now, there is an ethical duty here. Nurses are asked to provide information and are given a lot of responsibility. On the other hand, sometimes they are not given enough or the proper level of authority for decision-making regarding a patient. The healthcare team should work in collaboration, but sometimes it does not. So what will you do when you as a nurse get into the situation where you think that the patient is capacitated or not, or you think that the level of information that has been given to the patient is not sufficient, or there's a huge disagreement between other members of the healthcare team? This is the dilemma, and this is the paradox.
Ethical grounding.
The ethical grounding for informed consent should be very familiar at this point. The patient's right to participate actively in medical decision-making is based on the principle of respect for autonomy.